I'm going to turn off the light so you guys can see the screen a little bit better. Okay. What this does is really emphasizes the use of lifts when transferring residents. Um, the cost associated with injuries in the healthcare industry are estimated to be over $20 billion annually. And that's a figure from the National Institute for Occupational Safety and Health, otherwise known as NIOSH. For employees, the cost associated with injuries from transferring residents or back injuries or lost time and lost wages, and if you're hurt bad enough, it could be a lower quality of life due to a permanent injury to your back. For employers, these injuries result in increase in insurance costs and increase in overtime and training. Because when somebody is injured and they miss work, then they have to pay somebody else to do that job. And if it means somebody's having to work extra hours, then they're paying those people overtime. And if they have to replace that person because of a severe injury, then they have the training and the recruiting cost involved in that. CNAs report the highest annual case of back injury cases according to the American Journal of Medicine in the healthcare industry, and that's because they do most of the heavy lifting. They're involved in most of the transfers. According to the Bureau of Labor Statistics, the healthcare industry experiences over 50,000 back injuries per year and has a 50% greater incident rate than general industry. Incident rate is a formula used by OSHA to compare one industry to another industry. And again, they have a 50% greater incident rate for injuries from strains and sprains. And then the healthcare industry also has a 50% greater incident rate for back injuries than the general industry. And again, that's because you're dealing with people and you're having to transfer people. Well, oftentimes, the resident is much larger than the person trying to transfer them. The main causes of back injuries in the healthcare industry are improper method of transfer, failure to use the correct equipment, unexpected resident movement, because when you're dealing with people, people are unpredictable, and slip, trips, and falls, because you're also working in an environment where there's going to be cords on the floor and equipment in the room, as well as furniture. When we talk about back injury, it's good to know how your back is built. First of all, you have your spine, which is made up of a series of vertebrae. The top 7 of those vertebrae are called your cervical area. The middle 12 your thoracic, and the bottom 5 is your lumbar area. That lumbar area, the lower back, is the most likely to be injured because we'll show you in a minute how your back is like a lever, and the further out you reach, the more pressure you put on that lower back area. Again, your spine, your back's made up of the vertebrae, that's your spine. The ligaments link the bones together. The tendons connect muscles to bones. The discs are like little pad or shock absorbers between your vertebrae. Your spinal cord and nerve root system, which is your neurological wiring system, and then the blood vessels provide nourishment to all these different parts of your back. Here's just a close-up view of your spine, and you can see the vertebrae, which is the bone. You can see the little disc, which is the shock absorber, the nerves, and the spinal cord. Oftentimes, when you have a disc injury, I know everybody's heard the term bulging disc. A lot of times that bulge comes into contact with the nerve root, and that's what causes the pain. There's 2 types of back injuries, and one of them are soft tissue injuries, which involve muscle, ligaments, and they're less serious. Soft tissue injuries can usually heal on their own with rest, where disc or vertebrae injuries are more serious and often require surgery. We'll get into a little bit more on the disc injuries. Vertebrae injuries, vertebrae is bone, so if you've chipped or cracked a bone, then usually that's going to require rest and a cast and that type of thing. Now your disc injuries, your disc is made up of 2 parts. The middle of your disc is called the nucleus, which is a mushy, moist center, and it's surrounded by a thick, tough layer called an annulus, which keeps that center in. And again, your disc acts as a shock absorber between your vertebrae. When you have a herniation, here's an examples of herniation from a lesser injury to a greater injury. The first one you see is typical of disc degeneration. With age, your discs get brittle, and you injure them over age, and they dry out, and so that little bulge at the top might be an indication of disc degeneration. The second one is a prolapse, often called a bulging disc, and where that disc may bulge out and touch that nerve that we talked about. Then the next, going down to the more severe injury, would be an extrusion where the annulus actually breaks and the nucleus goes outside the annulus. And then the sequestration, the nucleus breaks through the annulus and lies outside the disc in the spinal canal. So that's an example of disc injuries from minor to worse. Disc herniation factors. A lot of factors can increase your probability of having a disc injury. Tobacco use. Tobacco slows down the healing process. Oftentimes, if you have back surgery, your surgeon will ask you to stop smoking before you have the surgery, because if you don't, it may take longer to heal. Lack of exercise. Men with large bellies, often called beer guts, can put more pressure on the lower back and cause their backs to give them, and make it more probable that they have a back injury. Aging, again, as you age, the discs gradually dry out. They're not as resilient, and they're more prone to injury. Posture, if you have poor posture, you're putting more stress on your back. Incorrect lifting or twisting, which is what we're talking about in this presentation. And it's also good to point out that herniations can be acute, they can happen all at once, or they can happen gradually over time. So if you're young and you're lifting the wrong way and you don't really feel it, at the time, if you do it over and over again, by the time you reach 40, your back may start hurting you. So just because you're young and flexible now doesn't mean that you're not doing damage to your back, even though you may not feel it yet. This is what I was talking about before, how the lower back tends to be the most often injured, because your back is like a lever, and the further out you reach, the less leverage that you have, and basically it has the effect of making things weigh more. So the further out you reach, it may be a 10-pound weight, but if you reach way out to grab it, you could increase that weight to 100 pounds. Or if it's a 100-pound weight, you may increase that weight to 1,000 pounds. So the further out you reach, the more heavy you're making that object, and the more stress you're putting on your lower back. What makes resident handling risky? Well, it's risky because, first of all, you're dealing with humans who are unpredictable. Some of them may have dementia or Alzheimer's. They may strike out at you. They may not cooperate with you. They don't have handles like boxes do. You just can't predict what's going to happen. They're harder to get close to you. One of the safe lifting rules is to have, to get the person or whatever you're lifting close to your body, so you're not reaching out, putting more stress on that lower back, and it's hard to do with a human. So, lifting or transferring residents is much more dangerous than transferring a stationary object. NIOSH, again, the National Institute of Occupational Safety and Health, studies have shown that in general industry, the most weight that is safe to lift on a continuous basis is 51 pounds, and that's quite a bit of weight. And what they're talking about there, and that's in ideal conditions, is like at the end of an assembly line, the weight would be at waist height, and they would be transferring it to another position at waist height. So that's ideal conditions. So, but when you're transferring a person, those aren't ideal conditions. Again, that person often weighs a lot more than 51 pounds. They may weigh twice as much as you do. They're unpredictable. They're prone to movement. So NIOSH researchers have reported that no caregiver should lift more than 35 pounds of a total resident's weight. So what that says is you really should, if they cannot stand and pivot and give you assistance, then you should be using a lift. Let's talk a little about ergonomics and ergonomic aids. Ergonomics comes from the Greek word ergon and nomos, which is the Greek word for law. So what it means is the law of work. But what ergonomics is a very simple concept. It's just developing tools and ways to make things easier on your body. It's fitting the task to the worker rather than the worker to the task. A lot of people do this on their own. You'll see people come up with ways to make jobs easier, like maybe they're sitting in front of a computer and they put a pillow in their chair so that they can get up a little higher. It makes it a little easier to reach the keyboard. Or they prop their feet up on a cardboard box. All those are both examples of ergonomic aids that make the job easier for them to do. Or maybe they're doing a work on a keyboard and the edge of the desk is cutting into them, so they put a pad on there to cushion it. Maybe they put a little pillow down there. Again, that's an ergonomic aid. When it comes to healthcare, there's been a lot of ergonomic aids developed over the years. One of those is a gait belt. We talked about humans not being like boxes and not having handles. Well, if you use a gait belt, that's essentially you're giving that person a handle. You have something to grab hold of. A walking belt is a similar idea where you can support the resident and give them some support by using a walking belt. A trapeze bar is a bar where the resident can pull up and assist you if you're trying to get underneath them to change out a bedpan or a sheet or something like that. Toileting chairs, toilet seat risers, shower gurneys, and low friction sheets are all aids that have been developed for the healthcare industry. And if you have those, then you should use them because they'll make your job easier. Okay. When we talk about lift equipment, there's a lot of different types of brands and manufacturers out there. I think you guys have a Sarah lift, which is a sit-to-stand lift, and you have a Marissa lift, which is a full-body lift. May have those reversed. But any brand can make, like Hoyer is often used a term for a full-body lift, but Hoyer also makes a sit-to-stand lift. So again, full-body lift and sit-to-stand lift. You guys have the brand names Sarah and Marissa lifts. The sit-to-stand lift, there's an example of it. I saw you guys have two of them upstairs. And then you have a full body lift, and that's for someone who is not mobile at all. Why do you want to use lifting equipment? Basically because people weigh too much to move without equipment. So if they can't stand and pivot, then you should use a sit-to-stand lift or a full body lift. Myth or fact, warehouse nurses are stronger than warehouse workers. If I get the same answer, are y'all stronger?
Yes.
I've heard yes in every other. This is the third one I've done, and the first two said yes, that y'all were stronger than warehouse workers. So regardless, what the point we're making here is warehouse workers, if you go in a warehouse, you will see very little manual material handling, okay? They'll have pallet jacks, hand trucks, forklifts. They have a lot of mechanical aids to move material with, okay? So same thing with you guys. We're talking about moving dead weight, or people who are moving, even people that are moving around and can assist a little bit. You still need an aid, things to help you do that lift. So if warehouse workers get mechanical aids, then you should feel comfortable using one as well. Using lifts slow you down? Maybe, they might. And the study's saying that they don't, that this presentation, but yeah, you may have to go get a lift. It may take you a little while to get that person, situated to get into the lift. But the thing is your back is worth a lot. And if you injure your back, it could lower the quality of your life for a long time. So it's better to take that extra 5 minutes and use that lift. Now I know there's certain issues, dignity issues and that type of thing. But I think in most cases, if that resident cannot stand and pivot, then a lift should be used. Myth or fact, residents don't like to be moved with slings or lifting equipment. I think some of them don't, and some of them do. It's the same deal. This presentation says research shows that when asked, the majority of residents feel safer when handled by sturdy equipment. Again, some people may and some people may not, but what we need to do is educate them and let them know that it is safer for them and it's safer for you, and try to go that route. A lift can be used anywhere. Well, we know a lift can't be used anywhere because you have tight spaces, and you also want to make sure that you have the correct lift for that individual. For instance, if it's a bariatric patient, you want to make sure you have a lift that will handle that amount of weight. If the person can support weight once they're standing, then you may want to use a sit-to-stand lift. Some of the risky jobs are lateral transfers, like moving residents sideways from a bed to a stretcher, transferring residents from sitting positions, because when they're sitting, you're having to bend over, they're going to be below your waist, and you're going to be handling a lot more weight that way, and it's going to be a lot harder on your back. Repositioning, moving beds, moving residents that are in beds is very risky because you have to bend over and reach. And again, when you're reaching, you're putting more stress on your lower back. And then, of course, you'll have residents who fall. And when residents are on the floor, it's very risky, and you really should use a mechanical lift unless they have some ability to get up on their own. I'm going to skip through this here because I just talked about these two. Okay. A falling resident. Who can tell me what you do if a resident starts to fall? You CNAs out there, what have you been trained to do?
You ease them down to the floor.
Ease them down to the floor, exactly. You don't try to catch them, because if you do, you're trying to catch a lot of weight. You have 100 pounds, it just drops like that, you're going to do some damage. So yeah, you try to, you don't try to catch the resident. You guide them to the floor, you bend your knees, you try to keep them as close to you as possible, and basically you break their fall and kind of go down with them, But you definitely don't want to try to hold them up, because then you're going to strain yourself. Care plans. How do we know how to transfer a resident? When you come to that, maybe you've got a new resident. How do you know what that resident's capable of, what they're not capable of? And there's where the care plan comes into being. The care plan is going to be done either by your therapy department or by your nursing department when the resident's admitted. They're going to assess the ability of the resident to provide assistance, the ability of the resident to bear weight, to cooperate, how strong they are, and how big they are. So all that's going to be assessed. You should have something like this at the nurse's station or available to you. Somebody's taking the staple out of this one. And this is kind of like a quick look at a certain resident. Their name will be in here. It says whether they can use a 1 or 2 person assist, or whether they need a Marissa or a Sarah lift, and basically you'll know how they're supposed to be transported, or transferred, excuse me. However, just because it says that that person, can be moved with a 1 or 2 person assist, they may be having a bad day, so you really have to assess that on your own. That gives you a starting point, but then you go in there and you do an assessment on your own and say, hey, is this person am I capable of transferring this person safely? Again, when you get ready to make a lift, the first thing you want to do is review that care plan and see how they're supposed to be transferred. Then you want to look and see if anything's changed, if the resident's condition has changed. Determine if they can stand and pivot. Determine if they're capable of understanding your communication. Are they agreeable to accepting assistance? They may be able to stand and pivot, but if they don't want to, then you have another problem. Does the resident have a medical condition that could make them prone to fall or injury during transfer? We had a recent injury, I think, at this facility where the resident was wearing a boot because he had hurt his foot. He couldn't support weight on that foot. That wasn't in the care plan. That wasn't a normal, that was something that happened after the care plan was developed. So he might have been a 1 or 2 person assist, but since he had a medical condition, that might have turned him into a full body lift. So again, assess that situation. Assess the environment. are the floors dry, or is there any water in the floor, are there cords in the floor, or the furniture or equipment in the way. So when you're transferring from A to B, make sure that you have a clear path to do the transfer. And then again, plan your lift to make sure that you have the equipment available. If it calls for equipment, make sure that the environmental hazards, that water in the floor, those cords in the floor have been assessed. Decide if it's safe to proceed. If it is, use proper body mechanics. Make sure that you know how the resident's reacting. Make sure that your coworker, that you communicate with your coworker. Let your coworker and the resident know what you're about to do, and then make the transfer. Above all, you don't want to put yourself at risk. If you look at the situation and say, hey, I just don't think I can do this, I may get hurt, the resident may get hurt, then don't do it. That's when you need to elevate it and say, hey, how are we going to do this? Plan for the lift or the move, don't rush, and most importantly, use your head and think. So, any questions about that? Any of that doesn't make sense to you?
Could you explain the two-person lift? Do they understand that too?
What part?
Bring that up. I know it came up in the last session, but that at the minimum there should be a two-person lift when you're lifting.
Yeah, that's according to management here, that at the minimum that you guys are required to use a two-person lift. So there really should be, if that person cannot stand and pivot. So if you're doing a lift on someone who cannot basically stand and pivot, that means stand and make a turn, then at the minimum, you should be doing a two-person lift, okay?
Or more.
Yeah.
Keep in mind that 35 pounds is really the safe limit.
Yeah.
So you can add up the numbers, but the idea is to be planning for these lifts and working with your department management on, what the expectation is. And certainly if you're not in nursing and home care is totally different. That's something you're going to have to talk with management and the family to decide on whether a lift, something needs to be purchased for the family or for the person in that home setting. But if you're in other departments and you see certain things happen, this is, again, it's your opportunity to kind of help assist. You don't have to lift. We're not asking you to lift. We're asking you to help make that person feel comfortable. We had something recently in dining where there was a fall right on the dining down in the bistro. And it was critical that people there knew what was going on and what was the safe reaction to that problem, because more problems could have happened as a result if we tried to pick that person up in the wrong way and we weren't trained to do so. So this is a method to kind of bring awareness to what the requirements are.
Yeah, and your home health residents should be able to stand and pivot. They should be, that should be personal care. You shouldn't be having to do a full transfer with those residents. If you are, then that means you should, talk to your managers about it and then see if there is the possibility of getting a piece of equipment for that resident, or either making sure that there is another person there to help you when that person gets up, when there's things that need to be done like toileting or getting up in the morning. So, but again, you shouldn't be doing that on your own, and you don't want to put yourself at risk. So.
If you would like a copy of this presentation, I will put it on the company shared drive, and I'm going to try to put it on DocDelivery as well, so you can view the PowerPoint. And if you don't have any more questions, make sure you've signed in to get credit. Ideally, you should be here for the whole session. If you haven't, I'd like you to watch the full video at some point. We did videotape it. We will have that available in the next couple weeks. And thank you all for coming. Don't forget to sign in.
Thank you.
Thank you.